an important focus of this course is giving people information about the risks and benefits of cannabis. But making a decision about whether or not to use a cannabis product is not just about the risks and benefits of cannabis. It also involves comparing the risk-benefit ratio of cannabis against other traditional treatments. Most of the remaining modules are focused on specific medical problems. These modules will provide an overview of the medical problem and underlying causes, discuss the risks and benefits of traditional treatments, and then discuss what we know about cannabis with respect to that specific problem. Module 5 is focused on the number one reason that patients report when they're asked why they use medical cannabis. That reason is chronic pain. All of us have experienced and are very familiar with acute pain. The sensation of acute pain is adaptive. It provides immediate feedback about potentially dangerous stimuli. Chronic pain is different. Chronic pain is pain that lasts for at least 3 to 6 months and sometimes 2 years. Chronic pain can be debilitating, making it difficult to work or function. It is a big problem in the U.S. and worldwide. Recent estimates suggest that about 50 million people suffer from chronic pain in the U.S., and that number is going to increase as our population ages. While there is a clear socioeconomic burden in the U.S., there's also a heavy individual burden for those who suffer chronic pain. At the individual level, chronic pain is also difficult to understand for both patients and healthcare providers. Often nobody knows why some patients get better while many do not, why some treatments work and others do not. And as a patient, that can be incredibly discouraging. Imagine waking up to pain every day, not being able to work or function, talking to one healthcare provider after another, and trying many different treatments with limited success. It's not surprising that many of these patients also want to try cannabis, especially given the side effects of more common pain treatments like opioids. Estimates from the most recent published studies in early 2019 suggest that 63% of patients who turn to cannabis cite chronic pain as the reason, and that estimate is consistent with a number of other earlier studies. So what do we know about cannabis and chronic pain? Several high-quality reviews of studies have found consistent evidence that cannabis and cannabinoids provide some relief from chronic pain. However, it's important to know that there are different types of chronic pain, and as you know, many different types of cannabis. And studies have yet to provide a thorough assessment of different formulations of cannabis across the different types of chronic pain. We also do not understand how cannabis works with chronic pain. It's possible it has a direct analgesic effect on the intensity of pain, but it's also possible that it works indirectly by changing the way we perceive and interpret the pain, or by reducing stress and anxiety associated with the pain, or by helping pain patients sleep. Clearly, we have much to learn, and I hope you enjoy learning a little bit about chronic pain and cannabis in this module. Okay? So in this lecture, we're going to talk about chronic pain. Before we get to chronic pain, let's talk for a minute about acute pain. So acute pain, everybody has experienced, right? It's basically getting chopped down on a soccer field, getting kicked in the shin, it's a stubbed toe, it's a slap in the face, maybe a sore throat from a cold or a virus, it's touching a hot pan. We've all experienced these things. When you touch a hot pan, what happens is that there's a neural signal that's created when you touch that hot pan that travels up your spinal cord to your brain and creates the experience of pain. That signaling is very important because that signal of pain, basically your brain can then say, okay, I have to move my hand or I'm going to get injured, right? So it's a protective mechanism that basically allows you to hopefully not get severely injured. So acute pain lasts for a short amount of time, most often seconds to minutes, sometimes days, sometimes weeks. But the thing here is that we usually recover. We recover from acute pain, right? The cold goes away, your sore throat goes away, the headache goes away, your broken ankle heals. What is chronic pain? Chronic pain, the definition here is pain that lasts a much longer period of time. Here we're talking about pain lasting at least 3 to 6 months or longer. Oftentimes, chronic pain patients are experiencing pain over years. Again, what's discouraging here is that for chronic pain, oftentimes it's not treated successfully. And that chronic nature makes it very difficult. It also is very difficult for patients and healthcare providers to try and understand why. Why is this chronic pain not going away? And there's not always an obvious source, and as I mentioned before, oftentimes there's not a treatment that is effective. So this critical question you see at the bottom of the screen here is, why do some people develop chronic pain following an injury while others don't, right? So some people get injured, the injury heals, and they're perfectly fine, and some people get injured, the injury heals, and they develop chronic pain that lasts for years. So examples of chronic pain, and one of probably the most prevalent example is lower back pain, but also neck pain, jaw pain, joint pain, headaches, arthritis, cancer pain. They're all different types of pain. These are sort of common examples I list here. So there are, even though there are different examples of pain, these oftentimes are viewed in terms of the type of pain. And there are 3 or 4 sort of groupings that make sense in terms of the biology, and those are called nociceptive, inflammatory, neuropathic, and dysfunctional. So immediate stimulus-driven pain that is nociceptive in nature is triggered by an encounter with some stimulus, whether it's a heat or it could be it could be pressure, but that is how the pain signal is triggered. Illnesses like arthritis or cancer can produce persistent nociceptive pain, right? So there's persistent signaling. And again, though, as I mentioned before, nociceptive pain is normally adaptive. Like, there's an important reason why we're supposed to experience pain when we touch a hot object. And it's also important to note that when people don't have that adaptive response, bad things happen. So, for example, people who are born with congenital insensitivity to pain can die because they don't feel the injury, right, in time to change the outcome. The same thing is true for diabetics. So this pain signaling mechanism, this nociceptive pain, is normally adaptive, and it's important. Okay, there are 3 other types of pain that we'll talk about: inflammatory, dysfunctional, and neuropathic. So these types of pain are sort of summarized in this figure here, which was taken from a paper in Nature Neuroscience in 2002. So kind of an old paper, but I think a nice graphical depiction of what we're talking about here. The other reason I like this graphic is that in terms of listing some of the mechanisms in terms of the signaling, what you can easily do then is go in, if you are interested in doing a deeper dive here, you can Google, for example, TRPV1 and CBD, and maybe begin to see some connections between cannabinoids and some of these signaling mechanisms. But in any case, these are the mechanisms that signal the pain. That signal basically travels along nerves through the spinal cord up to the brain that creates the experience that we all have when we encounter something painful. All right, inflammatory pain. Inflammatory pain takes place after tissue injury and after inflammation occurs. And so basically there's a change in the system that involves inflammation and responsiveness, such that even normally benign stimuli or mild stimuli can cause or produce pain. In addition, the pain response to the painful stimuli are typically more pronounced and prolonged. And so inflammatory pain usually disappears after the initial injury is resolved. However, in chronic conditions, the pain can persist after the inflammation is no longer active. So again, in the chronic sense, that inflammatory pain can continue. And in some ways, it's like a form of pain hypersensitivity. And when we look at the animal literature, there's definitely a link there between pathological pain and immune system function in the central nervous system and periphery. So again, this type of pain involves immune system function and inflammation. And this peripheral inflammation can also impact neuroimmune signaling, right? So again, both in the CNS and in the periphery. This is important. Okay, so neuropathic pain is basically pain associated with nerve damage, right? We have peripheral neuropathic pain, we have central neuropathic pain. It can occur in the absence of any identifiable pain stimuli. Well, where does it come from? Well, basically it comes from damage to nerves. And that damage can result from infection. It can result from tumors or trauma or metabolic disease. Spinal cord injury is a big one. A stroke, MS. And we'll talk more about some of these in future modules. So what does it feel like? What do people experience? Well, oftentimes it's a burning sensation. It's a pins and needles sensation. Sometimes it's pain, like you'll experience pain just by clothes touching your skin. It's like putting on a shirt. And normally something that would not at all be painful, but in the context of neuropathic pain, in the context of nerve damage, can be very painful. So the mystery here, as I mentioned before, is the persistence. Why does the pain persist? And that's a difficult question for healthcare providers to answer. Patients find it very discouraging to think about, but it is this important question about why some people recover from acute pain, while for others it turns into chronic pain. There has been a lot of research on this topic, and there are some important variables that can either exacerbate this or potentially make it better. And we're going to spend a few slides talking about that. So this slideshow shows you the different factors that can influence the experience of pain. And so here we have our pain experience here and our pain signal up here. But these over here are things that influence that pain experience. The way we think about the pain is important. The emotions that go along with the pain are important. Our social environment, our social factors are important, and our behavior. All of these things can influence, either exacerbate or mitigate the pain experience. So how does it work with emotions? Well, pain itself is an emotional experience. Obviously, people are experiencing emotions that go along with this chronic pain, and things like fear and depression and anger often accompany pain. Negative emotions are another source of information to the brain, right? So the brain is receiving information both about the pain itself, but also about these emotions. And we know that the stronger the negative emotion, the greater the perceived level of pain. So that is the how emotions work, especially negative emotions. With cognitions is a similar kind of thing. These negative cognitions, negative thoughts, like this is horrible, I'll never get better, I can't survive this pain, my life is ruined. All of these thoughts strengthen the pain signal and make pain worse, make the experience of pain worse. Besides amplifying the signal, negative thoughts also can diminish a person's self-efficacy. That is the degree to which they're confident that things can get better. And of course that's important because you need some self-efficacy in order to effectively manage your pain. So this is very important. Also, the social environment is important. So there is an interpersonal context to this, right? We have people around us, family and friends, and their responses can make things better or worse. If they're overprotective, over solicitous, or maybe they just ignore everything, or they're negative or punishing, all these things can make pain worse. So some common responses to pain, sometimes family and friends can be overbearing. So in this lecture we're going to talk about chronic pain. Before we get to chronic pain, let's talk for a minute about acute pain. So acute pain, everybody has experienced, right? It's basically getting chopped down on the soccer field, getting kicked in the shin, it's a stubbed toe, it's a slap in the face. pain signaling, right? So again, both in the CNS and in the periphery, which is important. Okay, so neuropathic pain is basically pain associated with nerve damage, right? With peripheral neuropathic pain, with central neuropathic pain, it can occur in the absence of any identifiable pain stimuli. Where does it come from? Well, basically it comes from damage to nerves. And that damage can result from infection, it can result from tumors or trauma or metabolic disease, spinal cord injury is a big one, a stroke, MS. And we'll talk more about some of these in future modules. So what does it feel like? What do people experience? Well, oftentimes it's a burning sensation, it's a pins and needles sensation. Sometimes it's pain, like you'll experience pain just by clothes touching your skin. It's like putting on a shirt. And normally something that would not at all be painful, but in the context of neuropathic pain, in the context of nerve damage, can be very painful. So the mystery here, as I mentioned before, is the persistence. Why does the pain persist? And that's a difficult question for healthcare providers to answer. Patients find it very discouraging to think about, but it is this important question about why some people recover from acute pain, while for others it turns into chronic pain. There has been a lot of research on this topic, and there are some important variables that can either exacerbate this or potentially make it better, and we're going to spend a few slides talking about that. So this slideshow shows you the different factors that can influence the experience of pain. And so here we have our pain experience here, and our pain signal up here. But these over here are things that influence that pain experience. The way we think about the pain is important. The emotions that go along with the pain are important. Our social environment, our social factors are important, and our behavior. All of these things can influence, either exacerbate or mitigate the pain experience. So how does it work with emotions? Well, pain itself is an emotional experience. Obviously, people are experiencing emotions that go along with this chronic pain, and things like fear and depression and anger often accompany pain. Negative emotions are another source of information to the brain, right? So the brain is receiving information both about the pain itself, but also about these emotions. And we know that the stronger the negative emotion, the greater the perceived level of pain. So that is how emotions work, especially negative emotions. With cognitions, it's a similar kind of thing. These negative cognitions, negative thoughts, like this is horrible, I'll never get better, I can't survive this pain, my life is ruined. All of these thoughts strengthen the pain signal and make pain worse, make the experience of pain worse. Besides amplifying the signal, negative thoughts also can diminish a person's self-efficacy. That is the degree to which they're confident that things can get better. And of course that's important because you need some self-efficacy in order to effectively manage your pain. So this is very important. Also, the social environment is important. So there is an interpersonal context to this, right? We have people around us, family and friends, and their responses can make things better or worse. If they're overprotective, over-solicitous, or maybe they just ignore everything, or they're negative or punishing, all these things can make pain worse. So some common responses to pain, sometimes family and friends can be overbearing. Sometimes that, overbearing in the sense they're really trying to help, which is nice, but if it reduces a person's sense of control and self-efficacy, it actually can make it more difficult to manage pain. Discouraging a chronic patient from exercise or activity. Because you're trying to help them or protect them, that can make things worse over the long run too. Criticizing, abandoning, spending less time, ignoring people with pain can also cause feelings of depression. So the interpersonal interactions are very important in terms of the experience of pain. In terms of behavior, some kinds of behavior can make pain worse. It's natural, of course, to favor a part of your body that's hurt, but over the long run, that can be counterproductive. The injured part of the body can become weaker if it's favored. prone to injury down the line. People with pain may also avoid situations that they fear may make their pain worse, and avoidance has physical as well as psychological and social costs. Pain may also make it difficult to sleep, and we know that lack of sleep can worsen the experience of pain. Also, misusing or abusing alcohol and drugs, especially opioids, poses both pretty severe health risks, but also, in the long run, can make pain worse. These are all behaviors then that can influence the experience of pain. Chronic pain, it carries with it a significant burden. This comes from a paper, this graphic that's cited down here at the bottom of the screen. But you can imagine people who have chronic debilitating pain. There certainly are socioeconomic consequences. There are issues in terms of healthcare costs, and lost productivity. There's the emotional side of things. There's the social consequences in terms of problems with marriage and family relations. And of course, it can certainly take a toll on activities, right? It can disrupt sleep and work and leisure activities and so forth. So definitely the chronic pain carries with it a substantial burden. So to summarize, chronic pain is pain that lasts for months or years. It's complicated at both a biological level but also a psychological level. The etiology, that is the cause of the chronic pain, varies from person to person. It's very difficult to understand why it's chronic and where it's coming from. And of course, there are a number of impacts, negative consequences, the social, emotional, and behavioral levels can be very debilitating and can carry a substantial socioeconomic burden, not just for the patient, but also their family. Well, I want to say thank you so much for doing this. It's been so long since I talked to you, and we'll
I know.
chatting some more in the future. But thanks so much for doing this.
Yeah, absolutely.
And just to catch up, I mean, like it's amazing what you've been up to, man. You must be really busy, but also obviously you're super successful. So it's worth it, right?
Oh, thanks, Kent. Yeah, it's been really busy, as you can imagine, and I'm sure is completely the case for you. It's just a busy time, but I love what I'm doing, so that makes all the difference in the world, you know?
Yeah, that is very cool. It's very cool. Well, so I told you a little bit about the class. I'm teaching a class in cannabis and health, and we just talked about chronic pain, and I thought about some of the work that you're doing, and especially I thought it would be great to have you talk because you have a big P. Corey grant, and
Yeah.
the term patient-centered I think is so important. I thought maybe I could just start by getting you to chat for a minute about your P. Corey grant and what patient-centered means, and then we can kind of take it from there.
Yeah, that sounds great. So patient-centered is really interesting. There's been a big push at the National Institutes of Health and also, of course, PCORI, Patient-Centered Outcomes Research Institute, to really conduct patient-centered research. And what that means is that patients are integrated into all levels of decision making in the research project. So the expectation is that the investigators are partnering with patients to both design the study, to choose the outcome measures. ultimate goal is to ensure that we are conducting research that is meaningful to patients, not just the scientists, but the actual recipients of, the ultimate products of the research. And in the case of what I'm doing and what others are doing in terms of clinical research, it's particularly relevant because then we have confidence that the treatments that we develop and investigate will be more broadly disseminated and adopted by the key stakeholders because they have given us key input at every stage throughout.
Right. That makes total sense. So the public health significance obviously is greater the more you involve the patients, right? And I think it's interesting to me too because in the sort of the cannabis space, right? That's obviously some advocates out there who were very vocal, right? I think this is a great example of a space where we want more patient involvement, right? But that's true across the board, of course, also. But so we just talked something in the class about different interventions for pain, right? And so maybe you can tell us more about your big PCORI grant.
Yeah. So, an overriding philosophy and real issue in the country right now is that we're trying to treat pain at best and at lowest risk. And so de-emphasizing opioids is a huge national focus right now. And what we recognize is that some of the lower risk and evidence-based ways to treat pain involve psychological strategies or what we call behavioral medicine. And, there's about 30 years of science that really puts forward these treatments like cognitive behavioral therapy for chronic pain, as well as self-management, chronic pain self-management, as being effective for pain treatment. But they're not broadly integrated into pain care pathways in the United States. And multiple government agencies like the Institute of Medicine, the CDC, the National Pain Strategy, they have all put forward that in order to reduce opioid prescribing and to treat pain more comprehensively, we should integrate these strategies into pain care pathways at all levels, from the acute pain management to chronic pain management. And we just, even though that imperative is there, we haven't done a good job with implementation. And so in my PCORI project, we are endeavoring to conduct some of the first primary science on this topic, very specifically in patients with chronic pain who are taking long-term opioid prescriptions and have agreed to voluntarily taper down on their doses over the 1-year period that they will be enrolled in our clinical trial. So our study is called the Empower Study. It's effective ways of managing pain and opioid-free ways to enhance relief. And the Empower Study, the title, the logo, and even our outcomes were informed with patient stakeholder input. So patients, it's so cool. And they picked the coolest logo too. So if anyone wants to see that, you can go to empower.stanford.edu. You can see the study website and what patients chose for what they wanted to see, what was welcoming to them. And so fundamentally, this is an interesting project because we're not just testing, we're not just doing a comparative effectiveness study of cognitive behavioral therapy, 8 weeks of cognitive behavioral therapy, as well as 6 weeks of the chronic pain self-management program. We are doing that, but we're doing all of this within the context of a patient-centered opioid tapering program. So we are enrolling in total almost 1,400 patients around the United States into our study. Of those roughly 1,400 patients, about 865 of them are agreeing to reduce their opioid doses. And then once those 865 people come in, they are individually, they're randomized to one of our 3 study groups, group CBT, group chronic pain self-management, or taper only. So even the taper only, sometimes people call that usual care, but all 3 of our study groups are actually getting care. They're getting a taper. But we hypothesize that the patients that receive one of our two evidence-based behavioral treatments for pain will evidence enhanced outcomes in terms of greater opioid dose reduction, greater pain reduction, and also improvement across a range of outcomes that are meaningful to patients, such as function and participation in social roles. Patients just want to live better. You know, they actually don't care so much about their opioid doses. They just want less pain, and they want to be able to do more.
That's right, absolutely. Well, so that's very interesting. So I imagine, too, because obviously we're interested in the cannabis angle also, you must have, well, I should ask you, how do you treat cannabis use? Is it a screen out or rule out? You just for the data? Like, yeah.
So I should tell you that the prequel to the Empower study was a pilot study that we conducted in Colorado and published in JAMA Internal Medicine about this time last year. And in this study, we invited patients to participate in a voluntary patient-centered opioid reduction program. And the patients that we enrolled were all on moderate and high-dose opioids. So all the way from 60 morphine equivalents per day all the way up to 1,005. So this was really a clinical sample, moderate and high-dose opioids. We found that of the patients who enrolled in our study, 37% were also using marijuana. And so that was interesting to us that a lot of people taking opioids may also be medicating pain and other symptoms with cannabis. And so one of the questions that I was interested in is, as these patients were tapered their opioid doses over 4 months, would we see cannabis use increase? And we actually didn't find that, Kent. We found that we didn't have a large enough sample to really test differences. It was like 18 patients were using cannabis. But not only did we find that cannabis use did not increase as patients tapered, there was a slight signal for cannabis cessation, where something on the order of 3 or 4 patients reported stopping their cannabis at the same time that they stopped their opioids. That was really interesting to me. So now, in our much larger clinical trial, the Empower study, we have systems in place to very carefully assess cannabis use, the amount, the type, whether it's prescribed or recreational, and tracking them very closely over the course of the year that they're involved in our study, so that we can begin to understand these relationships between pain, opioid use, behavioral pain medicine, opioid use decreasing, and what happens to cannabis use in the context of that.
Well, that's fascinating. That's actually, I mean, that's going to be amazing data to look at later, right? It's interesting. I just spoke to another investigator, Zita Cooper, down at UCLA, and she did a study, and this is published 5 or 6 months ago, but looking at the combination of an opiate and cannabis and showing that they work so synergistically to produce a more effect on pain, basically, right? So not that one substitutes for the other, but that there's something about the combination. But it's interesting because what you're saying is they kind of go up or go down together, and in some ways that might make some sense based on what she was finding. But the thing about this, of course, we have no idea what's going on, right? This is the science is lagged so far behind what people are doing that we just have no clue, right, how it works.
That's true, and I think that, a factor that's really underappreciated is that the methods by which you conduct a prescription opioid taper matter greatly. And a lot of physicians in the community, almost all of them, lack clear guidance on how to appropriately and compassionately reduce prescription opioid use. The guidelines that exist right now are too aggressive for our patients who are on high doses or patients who have been taking opioids for years or even decades. And if we go too aggressively in a prescription opioid taper, it amplifies pain, it amplifies distress and withdrawal symptoms, pain being a primary symptom of that, and it leads to a lot of failed tapers. So in the context of this, I could see that if patients are force tapered or if they're engaged engaged in a taper that's too aggressive, that they could increase marijuana use in order to self-medicate the discomfort of the taper, not necessarily their baseline pain at all, but just the taper itself. And so this is a big focus nationally right now. I mean, the question of whether you should be on opioids or not on opioids, I care less about that. I am very focused on when we do decide to taper, we must treat patients with compassion. We must be mindful that we are not exposing them to brand new iatrogenic risks caused by an inappropriately aggressive taper that fails to account for the unmasking of some psychological symptoms and increasing distress.
Right, totally. Yeah, and I think it makes a lot of sense that the overcorrection, we just have some negatives too. So you just mentioned unmasking some symptoms, and I wanted to pass on a question for one of my students because they were asking about is there potentially any synergy between or interaction between the sort of psychological side of things and potentially the behavioral therapies and cannabis. And I think part of this discussion comes from too is, we just don't know if, A, how strong is the association between cannabis and changes in opiate use, and B, what would and pain, right? And what would the mechanism be too, right? Because it may not have a direct analgesic effect. It may be, as you just mentioned, maybe it's somehow helping people get over the withdrawal, or maybe some other psychological things that are unmasked. I don't know if you can comment all about, and of course you've seen lots of patients on the sort of cognitive behavioral side of things. If how you see cannabis playing out, and so I'm trying to pass on that question as best I can, and then you can help.
Yeah. Okay, so I think it's helpful first to come into an appreciation of the definition of pain. So the International Association for the Study of Pain defines pain as being a noxious sensory and emotional experience. So the definition of pain includes psychological dimensions. It's half of the definition. But when we talk about pain, we all pretend as if it's largely sensory. Oh, and there's these little cognitive and emotional, aspects that we should consider. That's actually baked in. So psychology is integral to the experience of pain, and they are inseparable. In truth, they truly are. We try to separate them, and we can arrive at some estimates of how some very direct psychological experiences can influence what a person reports as a pain score, the number that they tell us. But on balance, when we recognize that pain is really and truly a psychosensory experience, anything that impacts our psychology, emotional and cognitive functioning will have impacts on our sensation and what we report to be pain. So once we come into that awareness, I would say it's impossible for it not to be a part of the equation, 100%. The bigger question is, what are the large scale effects at a group level? And then we have to be mindful that it's really the individual differences that, matter, which comes back to the patient-centered research, where we want to focus on each individual and all of their individual characteristics that make them have a disparate response to the average, right?
That's super important. I think this is why I'm coming out full circle back to the patient-centered piece. But you're so right. We can do all this research and we look at these averages and across people, but ultimately there are big differences in terms of how people respond to these things and in terms of all the many factors that influence the outcome, right? So, yeah, I think you do a nice job of really highlighting the sort of the emotional, sort of sensory side of things, right? That isn't. I mean, obviously, cannabis has an impact on these things too, right? So it's pretty unclear how, but definitely multiple possibilities how cannabis might impact the sensation of pain and or the interpretation of pain and or the emotional side of pain, right? So yeah, it's and potentially for better or worse, right? I mean, you see going either way. So it's just it's a fascinating area of research.
It really is. It really is. I mean, no question about it. I mean, I'm not a pharmacologist and it's not my area, but I think the cannabinoid line of research, I'm really excited for more of that to come online and inform our understanding about, how, cannabinoid products that maybe have some of those psychoactive properties removed, how those could safely treat pain. The interesting thing about people in the community just accessing marijuana is that that's a whole different ball of wax, where, we're definitely engaging all of the psychological, aspects and influencing those. And we really can't say with any degree of confidence that that is safe or effective or helpful for our patients with pain, in large part because, all of the rules and structures around the research have been so rigid that we haven't been able to conduct much of the primary science.
Exactly. You're totally right. We certainly spent a lot of time in class talking about that, right? The barriers, and then what does that mean? What means there's no research? It means that basically, people who are marketing cannabis can sort of fill in that knowledge gap of whether they want, right? And of course, and there's so many things out there, that's why it's impossible to know what works and what doesn't work, right? Or what has the opposite effect, because people are using all the conversions, all different kinds. It's difficult to know. But yes, so I just want to say thank you so much. I know I'm touching kept you a long here, but it's so nice of you to do this. I really appreciate it. I'm looking forward to having a chance to talk with you in person. It's been a long time since we actually get a chance to chat. So
I know, it's been a real pleasure, Kent, and I'm really excited with all of the work that you and the group is doing at Colorado, and I look forward to seeing all of the results from that.
We'll have to have you down here sometime soon.
That would be great.
All right, Beth. Take care.
Yeah, you too. Bye.
Bye. So in this lecture, we're going to talk about the epidemiology of chronic pain in the United States. And we're going to start off with a 2012 National Health Interview Survey. And this is an in-person household health survey conducted by the National Center for Health Statistics. And basically, the sample size here is 8,781 people that rated pain persistence. That is the number of days of pain in the last 3 months, and how much the pain bothered them. A little, a lot, or somewhere in between. So based on this survey, and you can read more about this in this citation here, this paper, it was determined that 126 million American adults had chronic pain in the previous 3 months. 25.3 million adults reported daily pain. 23.4 million people report having a lot of pain. So you can see, even on slide number 1 here, chronic pain is a very big problem in the United States. So in 2016 National Health Interview Survey of 33,020 adults in the U.S., researchers focused on high-impact chronic pain, and they defined that as chronic pain that limited life or work activities on most days or every day during the last 6 months. So in this survey, they found that a little over 20% of U.S. adults had chronic pain. 8% of adults reported high-impact pain lasting more than 3 months while restricting one major activity. And you can read more about this at the CDC site down below as well. So this is a table that talks about some of the prevalence based on different demographic groups. So in this left-hand column here, you can see, for example, age groups, gender, race, ethnicity, and so forth, right? I just want to highlight a few important pieces here. This set of columns here is chronic pain. This set of columns over here is high-impact chronic pain. So, number 1, look at how these percentages increase with increasing age, right? Clearly there's a function here of increasing age where once we get over the age of 85, we're seeing the greatest prevalence in terms of pain. So another trend you will see here is basically that women are showing a higher percentage than men. White non-Hispanics are showing, at least in terms of chronic pain, not necessarily in terms of the high impact chronic pain. Showing a higher percentage. Less education seems to be a factor that's important. Not being employed, also a factor that's important. Poverty status. And then finally, this is also huge, basically being a veteran, right? Being a veteran in terms of chronic pain, that's a big difference there too. So these are factors that are important. Age, gender, and veterans, so or basically older people, women, and veterans, high risk groups, right? So this just basically shows you, and perhaps in a much more easy to understand graphical way, what I just said, right? Who's most at risk for chronic pain? Well, I mentioned females, I mentioned older people, I mentioned veterans, but also the other groups I mentioned as well. Okay, so just looking some more, getting into the details here in terms of the prevalence. There also was a big internet survey that looked at point prevalence of chronic pain, basically including 27,000 participants. And the point prevalence of chronic pain, and that was defined as recurrent pain lasting longer than 6 months, was almost 31%. Again, higher for females in the study, increased with age. And half of the respondents with chronic pain experienced daily pain, and the average pain intensity was severe, that's greater than a 7 on a scale ranging from 0 to 10 for 32% of them. So again, this is just highlighting how big of a deal chronic pain is. Low household income and unemployment were also significant correlates of chronic pain. So again, highlighting some of the same themes. So what about outside the U.S.? Well, there have been also similar studies in Europe, and with somewhat similar results. So this study cited at the top here suggested that 20% of the European population has chronic pain. Again, higher prevalence for women, increase with age. Another study found that in developing countries, there was higher prevalence of chronic pain conditions among females and older people. So again, same theme. And chronic pain was also associated with depression and anxiety disorders in developed and developing countries. So there's also a psychological or psychiatric component to this as well. So how does pain compare to other conditions? So this is according to the American Academy of Pain Medicine. Chronic pain is more prevalent than other significant medical conditions in the U.S. This is an interesting way to look at it, right? So here we're looking at the incidence of pain, chronic pain, compared to diabetes and coronary heart disease and cancer, right? So 100 million Americans, roughly, are suffering from chronic pain, but only 25.8 million from diabetes, only 16.3 from coronary heart disease, 7 from stroke, 11.9 million from cancer. And the whole point of this graphic, right, is that to illustrate the extent of the problem, the extent to which our population in the U.S. is suffering from chronic pain, as compared to things you might think are prevalent. So again, highlighting just how prevalent chronic pain is. This gives you an example of just one kind of chronic pain, and I include this because we don't often think about the fact that something like rheumatoid arthritis can basically impact so many different aspects of functioning. But for those of you who have it, you know how this works, and it does impact the body and impact pain on many different levels, as illustrated here in this graphic. And obviously, you think about joint pain, but it is far more pervasive than just that. So arthritis can be one of the most debilitating of the chronic pain conditions, and it's worse in conjunction with other conditions. So this is just showing you severe joint pain among adults with arthritis, and that's higher with co-occurring additions, right? Co-occurring conditions. So in any case, it shows you how more prevalent it is when there's a co-occurring condition. So chronic back pain, I mentioned already, is probably the most prevalent. Is the most prevalent of the different types of chronic pain, different examples of chronic pain, and has basically doubled in the last 2 decades. And so in England, from the 60s to the 90s, it actually quadrupled. It's the most common cause of work disability. The burden of chronic back pain, it's the leading cause of years lived with disability worldwide. Estimated total costs are $100 to $200 billion annually in the U.S., mostly due to loss of work days. And the prevalence is high and increasing. Somewhere between 8 and 10% of adults meet criteria for impairing chronic back pain in a given year. It was 3.9% in 1992. It's the third most burdensome disease in the U.S. after heart and pulmonary disease. So this is just one type of pain that we're talking about here. That's the third most burdensome disease in the U.S. So here's that same similar kind of graphic for low back pain. And you can see here which factors exacerbate risk for low back pain. Important to note up here, sleep disturbance, right? But also depression and also age are also important. So what about headache? Headache is yet another form of chronic pain. There are different forms of headaches and migraines. So this slide just shows you some of the risk factors for being at risk for headache, and that includes comorbid psychological disorders, comorbid medical disorders, and women are also more at risk. Chronic nerve pain is another example, a common example of chronic pain. This is a form of course, neuropathic chronic pain. It happens when the nerves are compressed or damaged or exposed to drugs. And sciatica is often caused by nerve compression. Diabetic neuropathy we'll talk more about in the module on type 2 diabetes. But oftentimes this is felt in the extremities like the hands and the feet. Carpal tunnel syndrome is also one form of this that's associated with repetitive motion. Post-herpetic neuralgia, trigeminal neuralgia are also examples of chronic nerve pain. So to summarize, it's clear that chronic pain is a big deal, is a big problem in the United States. We're talking about more than 100 million adults in the U.S. reporting some chronic pain in the last 3 months. That number is more than the number of people who suffer from diabetes, heart disease, and cancer all combined. 25.3 million adults in the U.S. report daily chronic pain. There are major socioeconomic costs to this, and as you'll see in the next module, also this is the primary driver of the opioid epidemic. 3 things to remember in terms of risk factors. Increasing age is a risk factor for chronic pain. The veteran population, so being a veteran is a risk factor, and of course there's a link with females, so being female is also a risk factor.